Howdy, this is Indications and Applications of Joint Mobilization following rotator cuff repair, presented by me, Scott Fitzwater, Physical Therapist Assistant, for the class Outpatient Care Practice 0-20AU05, presented by Professor Dr. Andrea Aruskin. I've included a bit too much in this presentation, so if I rush through things to meet the time limit, I apologize. The reason that we're doing this is because shoulder pain is fairly common. It's the third most common musculoskeletal injury in primary care. Rotator cuff pathology accounts for 65% of shoulder pain complaints and about 4.5 million physician visits every year. And there are 460,000 orthopedic surgeries performed on the rotator cuff repair, making it the second most common orthopedic surgery performed in the United States. To learn how to properly perform peripheral joint mobilizations on the shoulder, it's important that we look at some of the landmarks. The shoulder itself is comprised of 3 synovial joints and 1 functional joint. Those joints are the sternoclavicular, the acromioclavicular, glenohumeral, and then the scapulothoracic. We'll be focusing most of our time on the glenohumeral and on the scapulothoracic, though addressing the sternoclavicular and the acromioclavicular could definitely come into play, but to a much lesser degree than what we'll be looking at. The 3 real important landmarks that we will need for our joint mobilizations are the acromion, which you find by locating the spine of the scapula and following it superiorly and laterally, and anteriorly, until you find the head of the acromion there. And also the spine, or the medial edge and inferior angle of the scapula, which you find by following the spine of the scapula again until you reach the medial border, then following that inferiorly until you find the inferior angle. The kinematics of the shoulder: the glenoid fossa is concave and the head of the humerus is convex. So as the convex surface of the humerus slides in the opposite direction and rolls in the same direction as the movement of the humerus. Some of the important muscles are the four rotator cuff muscles and the long head of the bicep, and you can kind of see their functions there, but I'm sure you're pretty familiar with those, and that's a real straight line. Out of those, we commonly deal with the supraspinatus, because impingement really affects that, and abduction is very difficult, and the infraspinatus, because external rotation is so limited, very typically after rotator cuff repair. Here we have the ranges of motion, so these are kind of our goals, things that we're looking for, and you'll notice that there are 2 sets of those. We've got the standard, which are much higher, flexion 180, compared to the mean for the elderly age range of 61 through 93 years of 165 in flexion, 38 in extension versus the standard of 60, 157 of abduction, which is pretty close to the 180 in abduction. Then IR, or internal rotation, and external rotation, both about 5 to 10 degrees off from the average. Now it's worth noting that these averages here have about 10 points of standard deviation on all of them. Now, the actual joint mobilization techniques. The indications we'll be looking at are to, first, restore passive range of motion, reduce impingement, reduce pain, increase range of motion, and for that, the grades that we're looking at are mostly 1 and 2. After things are healed and in the later stages of therapy, then you might get into 3, and you might get into 4, but we're going to be mostly talking about 1 and 2. Passive range of motion is a manual skill, and could be argued to be joint mobilization. I just wanted to include it to note that it is one of the few truly passive activities that a patient can do following rotator cuff repair. And that active use of the rotator cuff muscles has been associated with increased risk of re-tear. Obviously, with the more massive the tear, the higher the risk. That is why it's very, very important to perform the actual truly passive range of motion. And to help you keep those ranges small or appropriate, in days 1 through 14, immediately post-surgical, passive range of motion, most importantly to patient tolerance and comfort, with the goals of external rotation, 35 to 45 degrees, internal rotation after day 7 of 35 to 45 degrees, and all of those are conducted in scaption, slight flexion, and in the scapular plane. Cloth under the scapula or under the elbow, especially when laying supine, can really, really help the comfort of the patient and prevent the anterior translation of the head of the humerus in the glenoid fossa, which contributes to that impingement. Abduction can be started following day 7 and flexion to tolerance. In phase 2, which are days 7 to 14, we are still looking to protect and allow the healing of the soft tissue, but gradually working to restore full passive range of motion. So we're looking for flexion between 0 and 125 with a goal of 145, and internal and external rotation to about 90 degrees, abduction to at least 45. And we're looking for full passive range of motion by week 3, so day 21 or so. And for that full passive range of motion, it's instructive to look at what the other shoulder has if it's free of pathology, or go back to the previous slides and reference those average numbers. So the first mobilization that we're going to look at is just a pure distraction. And the reason that we do this is to increase the amount of space in the joint and to reduce pain. As you can see here, the patient is in supine. Therapist has their hand on the axilla just distal to the joint space, and the force is laterally in the plane of the glenoid fossa, which again is situated a little bit medially anteriorly. This can be, once things heal, can be a sustained grade 3 to help increase range of motion and general mobility, but for the starting, it's going to be grades 1 or 2. But most importantly, as we addressed earlier, to patient comfort. The next mobilization we're going to look at is a caudal or inferior glide, and that is done to help increase abduction. The patient again is supine, with the therapist standing on the outside of the arm, one arm positioned in the axilla, again distal to the joint space, the other arm with their fingers just proximal to the acromion process. Then you direct force inferiorly, and again we're probably just going to use a grade 1, so just kind of into that resistance a little bit to patient tolerance to reduce some pain. Next one we're looking at is a posterior glide to increase flexion and internal rotation. This is the one most people are familiar with. An important note here is to have some kind of supporting structure under the scapula to prevent movement and allow better translation. Another important point is with this mobilizing hand that as it rests here on the leg needs to go down as well to support the translation of the entire arm. The last glide that we're looking at is an anterior glide to increase extension and external rotation. This can also be done with the patient in supine, but it's a lot more awkward. Again, like the last one, the legs need to bend to support the entire translation of the arm with the movement. Then lastly, we look at that functional joint of the scapulothoracic joint. And that's with the patient in sideline with the affected arm towards you, and a cushion between you and the patient, because you're kind of right there in their space, and those are sensitive areas right in front of you. And the goal here is just to move that scapula through elevation, depression, retraction, upward and downward rotation, protraction and retraction, and a little bit of winging. And that's why it's important to be able to trace that spine down and find the inferior angle, which you can see that she is cupping right there. Here are my references, and it looks like I went over a little bit, so I'll let you be here. Have a great day. I hope you enjoyed this.